Hello, and welcome to today's webinar for mental health professionals, State of the Science, Interventions for Anxiety in Older Adults, featuring Dr. Julie Wetherill. My name is Kesha Patel, and I am the membership manager here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You should have joined the presentation listening using your computer's audio system by default, but if you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. You will also have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A sessions throughout the presentation. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation. You will receive a follow-up email including the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credit. You will also have the opportunity to complete the post-test assessment after the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Julie Wetherill. Dr. Wetherill earned a BA at Yale and a PhD in clinical psychology with specialization in aging at the University of Southern California. After a geropsychology internship at the VA Palo Alto Healthcare System, she completed a postdoctoral fellowship at UCSD's Advanced Center for Interventions and Services Research in Geriatric Mental Health. She has been a member of the UCSD faculty since 2003. Dr. Wetherill's research, funded by the National Institute of Mental Health and the Department of Veteran Affairs, involves clinical trials of combined pharmacotherapy and cognitive behavioral therapy for geriatric generalized anxiety disorder and acceptance and commitment therapy for chronic pain. Dr. Wetherill holds a position as staff psychologist in the VA San Diego Healthcare System home-based primary care program, which provides comprehensive interdisciplinary primary care services in the homes of older veterans with chronic and disabling disease. HBPC targets veterans in advanced stages of chronic disease, particularly those at high risk of recurrent hospitalization or nursing home placement. I am now going to take a moment to pass the screen to our expert. There will be a brief pause while I do so.
Hi there. Am I sharing my screen right now?
Yes, you are.
Okay, fantastic. Well, thank you very much, Kesha. I appreciate the introduction and welcome to all of you who are attending. I'm very excited to talk with you today about the state of the science for older adults with anxiety disorders. So what I'm planning is for the first portion of my talk to present a lot of data. And then I'm going to present a case at the end, which hopefully will tie things together. If you have questions, obviously, please put them in the text box, and I will ask Kesha to point things out to me if I miss them, because sometimes when I'm focused on the presentation, I'm not so good at multitasking. So today we're going to talk briefly about the prevalence and consequences of anxiety in older adults, cognitive behavioral therapy versus some alternatives, particularly for late life generalized anxiety disorder, a little bit about medications for our prescribers and those who work with them, some data on age differences in response to psychotherapy, and then some new research on PTSD, hoarding disorder, and fear of falling. a little bit on mindfulness, and then some general recommendations for treating anxiety in older people, followed by the case. So a lot to cover today. These are data from a recent epidemiological study in 5 European countries plus Israel. And one of the important things to note, these are people over the age of 65. It's a multinationally representative survey. The main thing to note here is that the prevalence of any anxiety disorder, which is this green bar on the left, is higher than the prevalence of major depression, which is this blue bar kind of towards the right. And then we have dysthymia, which is not very prevalent, at least in this study. These are quite high numbers, you'll notice, 17% prevalence of anxiety disorders in this study. Usually we see them around in the 10 to 14% range. So I don't know if this is now that the baby boomers are aging and we know that there are higher rates of anxiety in the baby boom generation, if that's what that represents. But at any rate, the main thing here I want to point out is that anxiety appears to be more common than depression among older adults. Some of the consequences of anxiety in late life include morbidity. So we see elevated risk for things like cardiovascular disease, heart attacks, strokes, those kinds of things. There are some data indicating that mortality may be higher in individuals with anxiety disorders or chronically high levels of anxiety symptoms, even after controlling for depression. Increased healthcare costs are associated with anxiety disorders in later life. And then cognitive decline, including increased dementia risk. And it was striking to me as I was reviewing the literature in preparation for this talk, how much of the new research on late life anxiety has been these studies showing that anxiety is associated with cognitive decline. That seems to be a finding that was initially kind of speculative. Now we've seen this confirmed over and over again in epidemiological studies, in clinical samples, in primary care samples associated with PTSD, with generalized anxiety disorder, with just elevated anxiety symptoms. So I think this is real at this point. I think we have discovered that anxiety does pose a risk for cognitive problems in later life. Treatment, which is what everyone's here to learn about today. Many older adults do prefer psychotherapy to medications for anxiety. But one of the things we found over the years is that cognitive behavioral therapy, which is of course the kind of gold standard treatment for anxiety in younger adults, may not work very well, particularly for generalized anxiety disorder in older people, which is honestly the primary anxiety disorder we see, the primary anxiety disorder that there's been any research on. And that's very different from late life depression and midlife anxiety. I'm not going to talk about depression here, but the data are very clear that older adults do just as well with cognitive behavioral therapy and other psychotherapies if they're depressed as younger adults do. But that's not true for anxiety disorders. So this is a recent meta-analysis looking at response to treatment for generalized anxiety in late life. And I have to say, the vast majority of research at this point has been on GAD. So a lot of this talk will be about GAD. For those of you for whom it's been a while since you've done or reviewed a meta-analysis, just to remind you, basically this is a statistical aggregate of many studies. And we compare the effect size of that aggregate to a 0 point. So for example, anything on this side of the line, the right side of the red line, suggests favoring CBT. Anything on the left side favors the control. This line of demarcation, red line of demarcation, means no difference. So if you compare CBT to a wait list or to treatment as usual, clearly these figures are on the right side of the line, so CBT is better than nothing. And I do say nothing advisedly. In older adults, treatment as usual, unfortunately, typically means no treatment. When we look at CBT versus any kind of active treatment, be that supportive therapy, be that discussion group, we see that this, although most of this figure for the aggregate effect is on the right side of the line, it does cross the line, the 0 line. So there's not a statistically significant difference between CBT and alternatives. And that is almost exclusively driven by this one study by Gretchen Brennes et al., which is fantastic, but you see there's quite a bit of other research that is not as powerful in support of CBT. So I'm not sure that CBT is better than alternatives for older adults with GAD. And that may be a different message from what you get in midlife or younger adults. Now, in terms of medications, the standard care for older people with anxiety tends to be benzodiazepines, still, unfortunately. They can be dangerous for older adults. They have risk of falls, in addition to the risks of various other kinds of addiction. There's also danger with benzodiazepines in driving. So for older people, SSRIs and SNRIs do appear to be effective, and possibly more so than CBT, at least, again, for generalized anxiety. This is another meta-analysis. This one is set up horizontally rather than vertically, but again, you have the same kind of layout where in this case, statistically, we're talking 1 is the line of demarcation here, but the blue bar suggests equivalent between treatment, which is below the bar, and control condition, which is above. So when you compare CBT to waitlist or to usual care, again, we see that it favors CBT. So CBT is better than nothing. When you compare CBT to either an attention placebo, which would be like a discussion group or something that controls for time and attention with a therapist, but is not supposed to be actively therapeutic, or CBT versus some other kind of therapy, so supportive therapy, for example, CBT, is not better, clearly better than those alternatives. On the other hand, if you're comparing a benzodiazepine to a pill placebo or an antidepressant, SSRI, SNRI, and the like, to a pill placebo, medications are better than placebo. So in addition to these kind of medication differences, we also find age differences in treatment response. It appears, and the data are not entirely consistent about this, but it appears that older adults may benefit less from psychotherapy for anxiety than younger people do. This is a study that we did in a large primary care sample. This was a study of a collaborative care intervention. So the comparison was usual care to a collaborative care intervention where a care manager either delivered CBT or provided consultation about medications to people with any of 4 anxiety disorders: social anxiety disorder, PTSD, panic disorder, or generalized anxiety disorder. And because this sample actually did include people over the age of 60, we were able to do a secondary analysis looking at older versus younger adults and how they responded to this collaborative care intervention. Most people in this collaborative care intervention did receive CBT. So although there were medications involved, most people got either CBT or, I believe, the predominant treatment was a combination. So when you look at all anxiety disorders, so this is GAD, again, PTSD, panic, and social anxiety disorder, among young people, the intervention, which is the dashed line here, was clearly better at 6 months, 12 months, and 18 months relative to treatment as usual, which is a solid line. And this was according to the BSI anxiety scale, which is a scale sort of broadly of anxiety symptoms. Clearly better at all time points. Among people over the age of 60, we see that initially through the first up to 12 months, some benefit for the collaborative care intervention relative to treatment as usual. But by the 18-month time point, there were no differences. So some amount of rebound on the part of the people who were getting the collaborative care intervention. Overall, there were age differences, but not by the end. The majority of people in the study did have generalized anxiety disorder. And so we did a cut separately. We actually did separate cuts by all the anxiety disorders. So if you want to read the paper, you can. But in terms of generalized anxiety disorder, again, we see this pattern where among younger people, people under the age of 60, the collaborative care intervention clearly superior to treatment as usual over 18 months. Whereas in the people over the age of 60, the treatment, the dash line for the collaborative care intervention, not clearly superior to treatment as usual and not statistically significant. So question here about whether this kind of intervention that includes CBT is less effective in older people than in younger people. There have been several other age comparison studies done over the years where they've looked at effect sizes in younger and older adults. Initially, in the Journal of Anxiety Disorders, there was a study comparing response on the Penn State Worry Questionnaire, because a lot of the studies use that particular questionnaire, so you could do clear comparisons. And they did find statistically significant effects or differences such that the treatment was more effective for younger people than for older people, and that was in GAD. More recent studies have not found statistically significant effects, but if you look at kind of the direction, and there aren't that many studies in older people, I will say, so even though they're not statistically significant, I look at these and I say, there does seem to be a pattern here. If I had to guess, I would say that CBT is probably less effective in older adults than in younger adults. That said, there was a recent study in which a primary care practice rolled out some interactive CBT. It was a web kind of intervention, and they took separate cuts by each of the different age groups that participated in this study. There wasn't a control condition, but they just looked at the decrease in an anxiety scale pre to post this iCBT program. And what they found was a main effect for age, such that older people had lower levels of anxiety consistently across the board than younger people, which is something we do find, but no interaction effect. So everybody seemed to do as well. So whether that speaks to the different kind of intervention here, I'm not actually familiar with this particular intervention. That is a positive result. We'll see whether we're starting to see perhaps in more recent trials a little bit of a better response by older adults. Okay, and I'm not seeing any questions on the chat box, so okay, I'm just going to keep going. We also did a meta-analysis a few years ago looking at different types of interventions only versus active control conditions. So the wait list, the treatment as usual. I'm not very fond of those kinds of studies, so we didn't look at those. But we looked at people with any kind of anxiety disorder or clinically significant anxiety symptoms, and we compared 3 different types of interventions. We have a CBT without relaxation, so there have been some studies done that have been very much more cognitive focused, cognitive restructuring, and so forth. There have been studies that have used the full CBT package, including relaxation training, and then there have been some studies that have just used relaxation alone. And as you can see, the highest, the strongest effects, the largest effects were for relaxation alone. So it may be that if you're doing a full CBT package, even perhaps because there's less emphasis or just less time spent on relaxation, that does not appear to be very powerful, and we really didn't see much of an effect at all for cognitive restructuring in the absence of relaxation. So that was sort of interesting. You know, I know in a lot of research with younger people, relaxation training is the control condition, but it actually does seem to be fairly effective for older people. So that's kind of one point to think about. Again, for folks who either prescribe or work with prescribers, or just in general clinical practice, you're going to see a lot of older adults who are already on medication for anxiety. So in practice, a lot of what we do is, in fact, combined treatment, combining medication and psychotherapy. And what we found is that adding CBT to a medication may boost response. So if somebody's had a partial response to medication, and also prevent relapse after the medication is discontinued. And again, this is in late life GAD. But this is useful because a lot of older people may not want to go on a medication. The thought that if maybe they can do that temporarily while they learn some skills and then discontinue as opposed to being on a medication for the rest of their lives is appealing. So this was a study that we did in 73 older adults who started out the study with generalized anxiety disorder. And we initially gave everyone open label escitalopram, 10 to 20 milligrams as tolerated. And then after that, we randomly assigned them to either receive cognitive behavioral therapy or not. And what we found, this is the Penn State Worry Questionnaire. So this is kind of the standard worry, sort of on the cognitive types of symptoms of generalized anxiety. We found a certain amount of decrease associated with the escitalopram alone, which was administered open label, and then a significant decrease in worry with the addition of CBT relative to just medication. So that was positive. In terms of the Hamilton Anxiety Rating Scale, this is more a measure of somatic symptoms of anxiety. So they ask about pounding heart and, kind of shortness of breath and those kinds of things, which may not necessarily be so prevalent in GAD, but are part of the package. And what we found was actually quite a substantial decrease in those symptoms with respect or after the introduction of the medication. So escitalopram seemed to be pretty effective on those somatic symptoms. Adding the CBT, which is this blue diamond line, solid line, added something. So there was some additional decrease in somatic anxiety symptoms relative to this dashed line with the triangles, that's the escitalopram alone. But this difference was not statistically significant. Now, if we had a larger sample, more time, we might have seen some differences, but basically, we saw the effect on worry, not so much on the somatic symptoms. So at that point, we then discontinued, we did kind of again, a randomized discontinuation of the medication for half the sample. So basically we had 4 groups. We had people who started out and everyone had the 12 weeks of escitalopram to start, but then they might have had, they were tapered to placebo and they had not had CBT, and those are the green diamonds. There were people that had discontinued their escitalopram, but they had CBT, and that's the triangles here, the yellow triangles. Folks who had continued escitalopram, but they had not had CBT, and that's the blue squares. And then folks who had both. So they continued on their medicine and they had also had CBT, and those are the red squares. So does that make sense? People kind of got that, 4 groups. So everybody starts out as doing pretty well, and then we're looking at who relapses. So the first group to relapse is the people who did not have CBT, they didn't learn any skills, and their medication goes away. And this is exactly what you would expect to see over 28 weeks. A lot of people with generalized anxiety disorder who don't have treatment are going to relapse. The next group was the people who also had their medication discontinued, but they had CBT. And those folks did relapse, about 25% of them relapsed, but that difference was not statistically significant relative to the people who continued on their medicine. And it was significantly different for the people who had not had CBT. Among the people in both of these squares, they continued on their medicine. The red squares, these are folks who had CBT. The blue squares are people who had not. Basically, everybody did well if they stayed on their medication. So there is some protective effect against relapse associated with having CBT. So don't want to say that CBT is useless for older people with anxiety, but it may be most helpful in conjunction with medicine. Okay, so you guys have heard some things, hopefully, in this talk so far, suggesting that our research has been limited in some very important ways. We've done a lot of studies with no treatment or wait list or usual care or minimal contact control conditions. So basically, we're comparing something to nothing. And in my opinion, better than nothing isn't very much. So we need to see more research that has active control conditions, and that's what I'm going to focus on from this point forward. We've also seen a lot of focus on generalized anxiety disorder, and I think part of that is that typically in epidemiological studies, we see more GAD in late life than we see other disorders. There's less panic disorder in late life, less PTSD. Phobia, you can see, depending on how people assess it, sometimes people will take an older person's word for it that, oh, I'm not really avoiding, I just, have other reasons to not do these things that used to scare me. But GAD is what we see. GAD is where a lot of the research is. We need to start looking at some other types of anxiety. And then finally, a lot of these studies have been on conventional CBT. And just it seems to me like, given that we're not seeing clear, strong evidence that CBT is a gold standard for older adults the way it is for younger adults, I think it behooves us to look at alternatives. And so we have been. There was a study just came out recently by Steve Thorpe and other colleagues here at the VA and UCSD, looking at prolonged exposure versus relaxation training for 87 older adults, so this is over the age of 65, combat veterans with PTSD. So these are people, obviously, if they're in their 70s now and they got PTSD in combat when they were 19, 20 years old, these are people who've been living with this for decades. And the prolonged exposure was very carefully taught and done. Edna Foa was involved in the training initially. The relaxation training was very manualized. And we measured the outcomes in two different ways. The CAPS is an interviewer-rated measure, and the PTSD checklist is a self-report. Basically, what we found was that there did appear to be effect. The darker line here is the prolonged exposure. The lighter line is the relaxation training. We found some effect for the benefit of prolonged exposure relative to the relaxation training post-treatment, but this tended to erode by 6-month follow-up. And the same was true for the self-report PTSD checklist. Some effects definitely observed at post-treatment, but these typically, these on average eroded by the 6-month follow-up. So PE may have some benefit over relaxation training, but at least among these folks who've been living with PTSD for decades, the effects may not last. Another recent study, we looked at older adults who had hoarding disorder, which is quite a significant problem, often sadly due to fires and other issues, fatal in older people. So we looked at 58 older people with hoarding disorder and compared CBT, very much the Steketee and Frost approach. They were involved in the training and in the manual and so forth, versus aggressive case management, which is a lot more than older adults in the community would normally get for hoarding problems. And again, the same sort of pattern. This adapted CBT for older people included some strategies to overcome cognitive deficits, because one of the things we see with older adults who hoard is some deficits, particularly in executive function. So these folks were taught some skills, calendars, compensatory strategies for their cognitive deficits, as well as exposure and response prevention, as you would do for even a younger person with hoarding disorder. And we did find effects immediately following the treatment, but over a 1-year follow-up, these effects were no longer significant. So once again, we see this adaptation of CBT for hoarding in older people does improve outcomes, but the effects may not be long-lasting. And finally, we did a study with 42, this was a pilot study, so 42 older adults with what we call disproportionate fear of falling, so people who were at objectively low fall risk as evaluated by a physical therapist, but who expressed at least moderate to severe levels of fear of falling on kind of standard measures. And we taught physical therapists to actually do this intervention in the home. The intervention did combine an exercise intervention plus exposure therapy. So people were doing the things that they had been concerned about doing due to fear, and some cognitive restructuring. And there were a couple of other components as well. We had a physician look through people's medications to make sure they were not on excessive numbers of kinds of medications that are associated with fall risk. We did have the physical therapist go through the home environment and make recommendations for changes like pulling up throw rugs and putting brighter lights on stairways and that kinds of thing. But anyway, what we found was definitely over the course of this 8-week intervention, we did find an effect for our combined integrated intervention, which we called ABLE, which is the blue line here. And the comparison condition was a very active, engaged, equal amount of time with someone who did fall prevention education. And again, we used a very solid, structured kind of educational intervention. We had homework and so forth. So we didn't see a lot of change in the people who got falls education on our fear of falling scale. We did see over the course of the intervention change due to our intervention, but unfortunately the effects eroded over time. We also looked at actual behavior. So this was a new measure that we developed that looks at actual behavioral avoidance. And we found some amount of improvement with our falls education folks, and a lot of improvement, particularly in the first half of treatment with our new intervention. But again, these effects eroded over time. So once again, we have an intervention that appears to reduce fear and avoidance, but the effects may not last. So all of this is beginning to kind of suggest that maybe these conventional strategies are not the best for older people with anxiety disorders. Maybe exposure isn't the gold standard the way it is for younger people. So, and the fact that relaxation and that kind of a strategy appears to perhaps be the active ingredient has made some of us shift our thinking and really start to look at acceptance and commitment therapy. And of course, ACT is becoming more of a gold standard even for younger adults. But it was something that myself and my colleagues were very enthusiastic about as a possibility for a lot of good theoretical reasons. Anxiety in older people is typically chronic. So many of these people have been anxious, honestly, all their lives. I have a lot of people who tell me they've always been anxious. People who tend to use more avoidant coping strategies tend to have more persistent anxiety, and that's true in a study we did of older primary care patients who we treated for GAD. We've also seen that thought suppression is associated with anxiety in older people receiving home health services. And finally, the whole concept of acceptance is really consistent with adaptive psychological functioning and aging. There are a lot of things that happen when we get older that we can't change. There are changes in our bodies, there are changes in our social environments, and if we fight against those changes, we're more likely to be distressed than if we learn acceptance. And there is a selective optimization with compensation model. If any of you have done any reading in geropsychology, this is a very influential model that's basically ACT, which was developed in the 1950s, but kind of the same theory as ACT. So we did an extremely small study. This was 16 people looking at ACT versus CBT for late life generalized anxiety disorder. And we looked at, again, that Hamilton, which is the primarily somatic symptoms, Penn State Worry Questionnaire, which is kind of those cognitive symptoms. We use the Beck Depression for depression, and the SF-36 for health-related quality of life. These, we actually, unfortunately, with such a small sample, we had big pre-existing differences, so I don't pay as much attention to those. But in terms of both the somatic and the worry symptoms, we did find some evidence that suggested that ACT might be helpful. And this is the dashed line here relative to the solid line. Now, of course, small sample, not significant, but enough to trigger some interest in ACT. And we actually have a study now going on in England where National Health Service psychologists and mental health providers are learning ACT and using ACT to treat older adults with treatment-resistant GAD. And we're just starting to publish results from that study, and it's very exciting. Not sure whether we would be able to get funded a study like that here, but I'm hopeful, at least for our work in England. But of course, all of this, the sort of the power of relaxation, the power of ACT, made me and others think about mindfulness. And I'm sure most of you have heard of mindfulness, most of you know. Mindfulness, of course, the most famous person associated with mindfulness training in this country is Jon Kabat-Zinn, developed mindfulness-based stress reduction. His definition of mindfulness is paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. Lots of research suggesting that it reduces stress, lowers cortisol, may even produce changes in brain circuitry, and enhances attention and other cognitive functions. So we did a study with 103 older adults with either an anxiety disorder or a major depressive major depression or dysthymia, so a diagnosed anxiety or depressive disorder. I will say that I believe about 3/4 of the sample did have an anxiety disorder, so it was a little bit weighted towards anxiety. And we looked at a number of different outcomes, but the main ones we were interested in were cognitive. So we looked at memory, and we actually found, relative to a health education control condition, that mindfulness-based stress reduction seemed to have a positive effect on memory. And I will say that this health education condition, which is in the blue dashed line here, this was based on Dr. Kate Lohrig's work. She is a researcher at Stanford. She's developed this chronic health self-management course, lots and lots of empirical support for this. It's a great intervention for teaching people how to manage their health. So we were giving people something of value as a control condition, something that is effective and powerful for some pretty important aspects of living with the kind of chronic conditions you experience in late life, but not with the active ingredients that we assumed that mindfulness would have. And sure enough, we did find significant group by time interactions supporting the red line here for MBSR. Conventionally, we also looked at symptom effects. So we were looking at excessive worry. And again, I think this was the brief Penn State worry questionnaire we've got here. And we found, again, significant differences in support of MBSR in the red line relative to health education in the dashed blue line. These were pretty much equivalent for the first half of treatment, so I think that's some evidence that just paying attention to people is important, which is why I don't like, why I think it's important to have control conditions. But by the end of treatment, this is post, we saw clear differences for MBSR relative to health ed. And here's the thing that really excited me. These differences did remain significant throughout a 6-month follow-up period. And we did ask people, and the fact is, most of our patients, 95% of our MBSR, participants who got MBSR, were continuing to practice at least some form of the mindfulness, even 6 months after we trained them in it. So this is, the first inkling that I've had that there may be some potential for an intervention other than continued use of medications that may have durable effects on anxiety in older people. Okay, so where are we at in terms of time? Okay, we're getting close to the case, which is good. So my general treatment recommendations for geriatric anxiety, and this is different from what I say when we're treating somebody whose primary presentation is depression. I believe that the first line treatment is an SSRI or SNRI medication, at least for generalized anxiety disorder. If somebody comes to me and they're a chronic worrier and they say, please help me, I don't want to take meds, no way, no how, I will say, well, I will do what I can, but I have to tell you that the data suggest that my friend down the hall with a prescription pad may be better able to help you than I am. That said, if somebody really doesn't want to take medication, I will do some relaxation training, certainly for generalized anxiety. CBT with exposure for panic, we do have some evidence for panic that I didn't present. There's not a lot of it out there. PTSD, phobias, especially if they're late onset. We do see better evidence for CBT for older adults with late onset disorders, anxiety disorders. Now, since most anxiety in older people is early onset, I think that's still, kind of limiting. And also consider ACT or mindfulness approaches. So those are kind of the things that I think about. And then after I've been working with somebody for a couple of months, if they're not getting better, I will switch into kind of a motivational interviewing strategy to really encourage a medication trial, especially when you think about the effects of untreated anxiety and those cognitive effects. Nobody wants to get dementia. Nobody wants to have to move to a nursing home and have people, watching them all the time to make sure that they're safe. So really important to get anxiety treated, whether you use medication or psychotherapy. So those are the kinds of things that we talk about. Definitely during the first month while somebody's on a medication, a lot of supportive contact, because a lot of older people, as I said, get nervous about taking a medication. So being really, kind of helping them kind of get over that fear and wait until the medication kicks in. Sometimes while they're on the medication, we can do some psychotherapy, and then if they can discontinue the medication after 6 months or so, oftentimes that is a more appealing prospect to somebody than kind of long-term use of the medication. So that's kind of how I handle, in general, how I handle older adults with anxiety. I think the next is the case. Before we move on to the case, does anybody have any questions? I'm still not seeing anything in the chat box. Okay, all right, well, I will keep going, but please feel free. Oh, okay, I'm just getting a notification. We'll do Q&A at the end. Okay, fine. So this is a case, I'm going to call him Mr. C, and this was someone that I did treat in my role as a psychologist in the San Diego VA's home-based primary care program. Mr. C was an 82-year-old widowed Italian-American man, and he was receiving our in-home services, which included primary care, so physicians, nurses, dietitians, social workers, physical therapists, and me all come to people's homes and help them. He was enrolled in this program. His main medical illnesses were COPD, diabetes, and atrial fibrillation. So a lot of our patients have a lot of different medical problems. He had been experiencing some cognitive decline, but he had never been formally diagnosed with a dementia. And he presented as primarily very, very worried about his breathing. That was kind of the biggest thing, constantly kind of thinking about whether he could do something without oxygen or, kind of what was going to happen to him. Excuse me. He also expressed some trouble sleeping, and he was not doing a lot in the community, and, was fairly disorganized kind of, again, I think, there was that cognitive issue, but he was having trouble getting it together to do things he used to enjoy. He had recently moved from a senior apartment complex where he knew a lot of people and he was doing a lot of interesting things, had a lot of friends, to an apartment complex that was not limited to seniors. And he was having trouble making friends. There were not the kinds of group activities that were offered. So he was quite lonely and he was bored. And also his son had recommended that he stop driving, which was, of course, very irritating to him, and also foreclosed some of the activities he had used to enjoy. So he was seen in his home by me, and initially the depression just seemed to be prominent. So I conceptualized this really as a depression case, particularly, someone who had used to have a lot of positive activities, positive reinforcement in his life, not able to do that as much because of his various limitations. So we started out with behavioral activation. We were using a calendar to kind of help him remember these various activities. But it turned out that he was forgetting to write things on his calendar. So it really wasn't very helpful for him. And he was forgetting to take medications, which was a great concern to our medical team. So we did get the patient's permission. The primary care physician and I talked about our concerns about his cognitive function, and then the primary care physician talked with his son, and there was kind of a lot of discussion back and forth, and he was also unhappy with his living situation. So in the end, he decided that he would be best served by moving to an assisted living facility, which we hoped would replicate some of those kinds of activities that have been available to him in the senior apartment complex. So he moved, but unfortunately, the new environment didn't work any magic. He was avoiding interaction with other residents. And when we talked more about that, delved into that a bit, turned out that he was really afraid of what people would think. He was on oxygen. Would they think he was, old? Would they think he was feeble? Would they notice that he was forgetting things? And he would get very worried about any kind of activity or appointment. Will I remember to go? Will I be able to get ready on time? So just lots and lots and lots of anxiety that seemed to be getting in the way. And in fact, the calendar, which initially we had sort of wanted to use to help with remembering things to engage in behavior activation, and he was forgetting to use it, now it became an anxiety trigger. So just the thought of having to deal with this was getting him anxious. So I said, well, maybe this really is not as much depression. Maybe the core problem here is anxiety. So we started doing some relaxation, we started doing some mindfulness training, and he was just not, not following through with any kind of practice assignments, and he began canceling sessions. I think, my appointments with him were stressful for him, which I understand. But in the end, he just decided to terminate psychotherapy. He did not think it was helpful for him. So again, we're part of a team. The primary care physician referred him to a geriatric psychiatrist, and that psychiatrist did prescribe an SSRI, and he was taking it. And part of being in the assisted living meant that people were helping him with his medication. So that part of the problem was much better in his new environment. So he was taking it. And he actually, his anxiety started to improve. He did start to use his calendar, but he was still complaining that he wasn't wanting to get out. He was bored. He, wasn't interacting with other people. He didn't like where he was living, and so forth. So I did not see him for a while because, again, he had terminated psychotherapy. And then I did go back about a year later just to check in with him. He allowed me to come and talk with him. And he actually was doing a lot better. His anxiety had improved. He had found some activities he was enjoying in his assisted living facility. He did have some people that he was connecting with. He was continuing to take the SSRI, and he was doing a lot better. So I was very happy to see that he had improved. So the take-home messages from all of this, I think, are first that it is perhaps even more difficult to distinguish anxiety from depression in older people than it is in younger people. And also hard to tease these apart from cognitive impairment. So for example, in the case of Mr. C, there was this amotivation, and do we conceptualize this as avoidance, as anhedonia, as executive dysfunction, as all of the above? I think it turned out to be all of the above in his case. We do find, of course, that anxiety is very common among older adults with cognitive and physical limitations. Sometimes environmental adaptations are necessary. So I do think in this case, ultimately, moving to the assisted living facility was helpful. I think obviously moving from his senior apartment to a non-senior apartment had been a trigger, kind of to bring on this distress. So environment does make a difference. Clearly, a multidisciplinary approach here was helpful, working with the PCP, working with the psychiatrist and the patient and his son, all combined together, I think, to have ultimately a successful outcome with this case. But he was difficult to treat. I mean, he did need all of that, I think. And I think a lot of times we see partial response, so people get somewhat better, but not well. He, I would say, got well, but it took a year. And that's a long time. We try to get people better faster than that. So that's all the material that I have. We've got about 10 minutes for questions. And,
hi, Julie.
Hi.
So we do have a few questions. Thank you so much for your presentation. We will take any last-minute questions in the chat box, and I will read them out loud. So you can still submit them as I'm asking questions, just for everyone in our attendee platform. We have a few right now. So the first question is, are you aware of any literature examining medical contraindications of doing interoceptive exposures with older adults with panic disorder?
That is a wonderful question. There have been, early on, before anyone had any data, a lot of opining took place in the literature from people saying, oh, you can't do exposure with older adults with anxiety because either they will have heart attacks or they will get demented. Now, I'm not exactly sure where that came from, but basically, if somebody is able to climb a flight of stairs, their heart will tolerate exposure therapy. That's what I've been told by Dr. Murray Steen, who is a psychiatrist. He's had the medical training and he's an expert in anxiety. We have not seen rates of negative medical or cognitive or other effects for exposure therapy for either panic disorder or PTSD.
Thank you. We have another question. It is. I've noticed that the older adults I've worked with seem to more frequently forget that they have done any homework, that they have any homework to do between sessions, and also seem to not have retained teaching I've done during sessions, as in from session to session. Am I seeing cognitive issues, or is this maybe more about perhaps why CBT might not be particularly effective in older adults? It's just confusing and I think frustrating for them and for me. Any thoughts?
Yes. So I think there are a few things that can be happening. One of them is that older people, obviously, it's been a long time since they've maybe been in school. So just the idea of learning or practicing something, and you really have to kind of say, well, when you were, did you ever play a musical instrument? Did you ever, play a sport? And, remember how much practice you had to do to learn those skills? Well, it's kind of like that here. So people kind of understand the mindset. I think that's part of it. I think certainly less so now with the baby boomers who are aging, but before that, people had stereotypes about what therapy was, and they didn't really think it was a learning, teaching kind of relationship. They thought it was, lie on the couch and tell me about your mother. So I think there's people's conceptualization of the problem and conceptualization of what needs to be done to treat it is a little different. But it is true that a lot of older adults do have some memory issues. So being able to spend a good portion of sessions kind of helping people figure out how they're going to work this practice into their lives. I also would never assign any homework that the person has not done sitting next to me or standing next to me in the session. So even if you explain something really thoroughly and send somebody home to go do it, they may not understand or remember. I also always make sure I give them written instructions, and I often, and this was a tip I learned from prolonged exposure, tape record, or I guess we don't use tapes anymore, electronically record the sessions, give the person, let them be able to listen to it. So the material goes in orally, it goes in visually, they have it to refer to. You can potentially, if they agree, to allow a support person, a spouse, or an adult child to facilitate as kind of a coach and to be present in sessions and to help remind the person to do the homework. All of those are strategies that can be used to improve adherence and help people get better faster. In terms of our own frustration, I have also worked teaching therapists who haven't had a lot of experience with older people how to work with older people. And people have sometimes been surprised to say, it takes longer, but they actually do learn. So if you sort of think, well, this is a case that I should be able to make progress on, I should be able to help this person in, 10 sessions, maybe think it's going to be more like 20 or 30. But don't give up hope that they're going to get there in the end.
Thank you. We have two more questions. The first is, do you have any data on effective interventions for older adults with OCD?
To the best of my knowledge, there have been no randomized control trials. I believe her first name is Cheryl Carmen, has done some case reports where older people have responded quite well to exposure and response prevention, particularly where they have family members who are there to coach them. But as far as I know, there are still no randomized control trials of older people with OCD.
Thank you. And our last question is regarding therapy options for older adults. Do you have any data around the effectiveness of existential therapy? My thinking is that so much of geriatric anxiety is around lifespan and health changes, and I know ACT may get at this variable as well.
Yeah, so that's another, there are definitely some kind of life review, people have called it, kind of discussions of, kind of things that wouldn't be exposure, wouldn't be relaxation. I don't think there's a lot of good evidence. Nobody's ever done a study comparing CBT to existential therapy. Now, ACT, of course, includes a lot of behavioral strategies as well as kind of the acceptance strategies. So I tend to be a bit skeptical. In depression, we've seen some studies where behavioral treatments have been much better than the kind of existential or life review kinds of treatment. So in depression, it's pretty clear that, standard behavioral stuff works better than these kinds of interventions. But if you have access to research facilities and resources, it would be interesting to do that kind of a study.
Thank you so much, Dr. Wetherell. I will now make myself a presenter again, so this will take a brief second.
I should say, please feel free to get in touch if anybody else has questions, or if you're watching this webinar after the fact, please feel free to call me or to email me, and I'm happy to respond.
Thank you so much. Thank you also to all of our participants for attending today's training. You will receive a follow-up email shortly that includes the link to the webinar evaluation, the webinar recording, and the post-test assessment for those seeking CE credits. Please stay on the webinar platform if you would like to take the post-test assessment after a few announcements. Our next ADA Live webinar, Resisting Myths and Reducing Shame, Understanding the Impact of Rape Culture on the Prevalence of Sexual Assault Within the African American Community, featuring Dr. Carmel Brown, will be held on Thursday, December 12th at 12 p.m. Eastern Time. If you're not an ADA member yet, we invite you to view the many membership benefits that ADA has to offer. ADA members enjoy year-long access to continuing education programs, free access to special interest groups, including the online peer consultation groups, promotion of your practice in ADA's online Find a Therapist database, a significant discount to ADA's annual 4-day conference, website listings of your clinical trials, support groups, and publications, free online access to Depression and Anxiety, ADA's official research journal, networking and collaborating with experts and colleagues from around the world, and more. Please visit adaa.org to learn more. We also invite you to register for ADA's annual conference on March 19th to March 22nd in San Antonio next year. On behalf of ADA and our presenter, we thank you for joining us today.